external cephalic version and reducing the incidence of term breech presentation. Green Top Guideline number 20A, March 2017. Purpose and scope. External cephalic version or ECV is the manipulation of the fetus through the maternal abdomen to a cephalic presentation. Introduction and background epidemiology. External cephalic version or ECV. How effective is external cephalic version in preventing non-cephalic birth? Women should be informed that the success rate of ECV is approximately 50%. Women should be informed that after an unsuccessful ECV attempt at 36 plus 0 weeks of gestation or later, only a few babies presenting by the breech will spontaneously turn to cephalic presentation. Women should be informed that few babies revert to breech after successful ECV. Women should be informed that a successful ECV reduces the chance of cesarean section. Success rates of external cephalic version or ECV vary. Overall success levels are greater for multiparous women, 60%, than for nulliparous women, 40%. Spontaneous version from breech to cephalic is unusual at term and occurs in only 8% of primigravid women after 36 weeks of gestation. Where ECV at term has been unsuccessful, only 3 to 7% of babies will spontaneously turn to cephalic presentation. Spontaneous reversion to breech after a successful ECV is rare, occurring in only 3%. Thus, external cephalic version affect the outcome of labor. Women should be informed that labor after ECV is associated with a slightly increased rate of cesarean section and instrumental delivery when compared with spontaneous cephalic presentation. Even after successful ECV, women remain at increased risk of cesarean delivery for both obstructed labor and fetal distress. There is also an increased risk of instrumental vaginal delivery. The risk of cesarean delivery may be greater with a shorter ECV to labor interval. Can the success of an external cephalic version attempt be predicted? ECV success can be predicted to some extent, but the use of models to predict success should not be used routinely to determine whether ECV can be attempted. Success rates depend on multiple variables. It is likely that case selection considerably affects success rates. A meta-analysis showed that multiparity, non-engagement of the breech, use of tocolysis, a palpable fetal head, and a maternal weight of less than 65 kilograms were predictors for successful ECV. Other factors such as posterior placental location, complete breech position, and an amniotic fluid index greater than 10 are also predictors for successful external cephalic version. There are limited data to suggest that estimated fetal weight affects success rates. What methods can be used to improve the success rate of external cephalic version? Use of tocolysis with beta mimetics improves the success rates of ECV. Routine use of regional analgesia or neuraxial blockade is not recommended, but may be considered for a repeat attempt or for women unable to tolerate ECV without analgesia. Beta-mimetic drugs may be administered routinely, reserved for where the uterus is tense or for where a previous attempt without tocolysis has been unsuccessful. A significant reduction in the incidence of cesarean has been demonstrated with the administration of beta-mimetic drugs where a previous attempt without tocolysis has been unsuccessful. A pragmatic regimen consists of 250 micrograms of salbutamol in 25 milliliters of normal saline, 10 micrograms per milliliters by slow intravenous injection or 250 micrograms of terbutaline subcutaneously. Beta-mimetics should not be used in women with significant cardiac disease or hypertension and will not be effective in those taking beta blockers. Maternal palpitations, tachycardia, flushing, tremor, and occasional nausea may be experienced. Regional anesthesia requires less force and may reduce failure rates, particularly in conjunction with tocolysis. The effect of regional anesthesia on cesarean section rates, however, is less clear. Some women might be helped by the use of clinical hypnosis prior to ECV. When should external cephalic version be offered? ECV should be offered at term from 37 plus 0 weeks of gestation. In nulliparous women, ECV may be offered from 36 plus 0 weeks of gestation. Gestation at term does not appear to affect success rates. There is no upper gestation limit for when ECV can be offered, but contraindications may be more common. There is no clear benefit to ECV prior to 36 weeks of gestation. In nulliparous women who have a low chance of a spontaneous version, ECV from 36 plus 0 weeks of gestation seems pragmatic. Spontaneous version in multiparous women is more common. There is a paucity of data on intrapartum ECV, but success has been reported. Intrapartum ECV may be considered if informed consent is possible, providing the membranes are intact and no contraindications exist. With an unstable lie, ECV is reasonable in the course of stabilizing induction. There are limited data on this procedure, but potential risks include cord prolapse, transverse lie in labor, and fetal heart rate abnormalities. ECV should only be performed if there is a valid indication for induction. What are the contraindications to external cephalic version? There is no general consensus on the eligibility for or contraindications to ECV. Women should be informed that ECV after one cesarean delivery appears to have no greater risk than with an unscarred uterus. There is limited evidence concerning contraindications for external cephalic version. Only placental abruption, severe preeclampsia, and abnormal fetal Doppler or cardiotocography or CTG are supported by any evidence. ECV is contraindicated where an absolute reason for cesarean section already exists, for example, placenta previa major. It is generally considered to be contraindicated in a multiple pregnancy, except after delivery of a first twin, where there is rhesus isoimmunization, current or recent, less than 1 week vaginal bleeding, abnormal electronic fetal monitoring or EFM, rupture of the membranes, or where the mother declines or is unable to give informed consent. ECV should be performed with additional caution where there is oligohydramnios or hypertension. The role of ECV with a previous cesarean section has been controversial. The largest analysis compared ECVs performed in women with previous cesarean section with ECVs performed in other multiparous women and concluded that ECV is safe and successful in women with one previous cesarean delivery as with other multiparous women.